Dear Chairman, thanks for the kind introduction. Before I start, I would like to thank the organizing committee of Fertility Academy for their kind invitation. It's my pleasure to be part of this meeting. In the next 25 minutes, I would like to discuss with you Luteal phase support in personalized approach manner. So I hope you will enjoy with the presentation and find it useful for your daily life practice. This is the disclosure, and I should stress that I will discuss not only the frozen embryo transfer, but also the fresh embryo transfer to maximize our reproductive outcome during the presentation. Let's start with the frozen embryo transfer cycle. As you all know, fat continues to increase dramatically over the last decades. And as you can see, in the United States, there's a threefold increase, an apparent increase in Australia, New Zealand, and Europe. Why there's such an increase? Because there's an increasing number of freeze-all cycles, also increasing number of pre-GTA cycles, also clinician preferences to avoid the risk of OHHS and to avoid from the late follicular phase progesterone elevation. At home at Hacettepe University in 2002, due to the lack of the antagonist, we did 85% of embryo transfer in a frozen embryo transfer cycle. In 2023, it reduced to 65%. Again, it's very high. We started with frozen embryo transfer cycle for the preparation of endometrium. As you all know, we do have two main protocols, artificial cycles or nature cycle. In artificial cycle, exogenous estrogen and progesterone will prime the endometrium for implantation. However, in nature cycle, we do have corpus luteum, either modified natural cycle or modified ovarian stimulation cycle. Corpus luteum secreted progesterone and also other hormones. And this prime the endometrium for implantation. So despite the growing evidence that natural cycles are much safer when compared with the HRT protocol in terms of perinatal and neonatal outcome, including the preeclampsia, hypertensive disorders, macrosomia, postpartum hemorrhagia, and C-section, despite these evidence, it's still most commonly employed protocol in Europe, also in the United States. According to survey, overall rates of HRT protocol is 77%, and in ovulatory women, even in ovulatory women, it's 70% of all cycles, done with the HRT protocol. Progesterone administration is crucial step for HRT protocol since we don't have endogenous progesterone. So different dose, different types, different routes of progesterone have been administered until now, but I should stress vaginal, intramuscular, subcutaneous, and oral dydrogesterone. But I should stress that lack of head-to-head comparative data in frozen embryo transfer cycle. Mostly the data is extrapolated for the dosage from fresh embryo transfer cycle. So based on this knowledge, should we standardize our LPS or personalize it? To answer this question, we have to answer another question, actually. Is there any interpersonal differences in serum circulating progesterone level despite giving same dosage of exogenous progesterone to your patients? We did a study and answered this question in 2020, published in RBM Online, measured serum progesterone 1 day prior to embryo transfer, providing the patients twice daily BID progesterone, microcrinon gel actually, and measure the progesterone. As you can see, there is a marked variation between patient to patient, ranging from 6 nanogram per ml to 36 nanogram per ml. So the question is, why there is such a large variation between, interpersonal variation between our patients? Actually, uptake, distribution, and metabolism may vary immensely for progesterone. As we learn from the studies, BMI affects the serum progesterone levels. According to 3 studies, higher BMI is associated with lower progesterone level. Also, female age, interestingly, higher the female age, higher the progesterone, maybe the absorption capacity of the vagina is changing by age, and number of previous birth affect the serum progesterone concentration. Also, the history of previous low progesterone level is an indicator for low progesterone in the current cycle. Only one study showed that sexual intercourse may interfere your serum progesterone concentration if you prefer to use vaginal progesterone. In the same study, we asked whether below or above which percentile may pregnancy rates deteriorated due to serum progesterone concentration. And we identify, despite it may be criticized due to low sample size, the 10 percentile cutoff, which is the cutoff threshold point is 8.75 nanogram per ml, associated with twofold lower ongoing pregnancy rate when compared with the other percentile groups. As I mentioned, this is a small-scale study, but along with our study, 11 other studies published, and we summarized all data in this publication in Frontiers in 2021. As you can see from this table, it's complicated. Different routes, different dose, and different types of progesterone has been used. Also, the measurement time is not standardized for all cycles, so to reach a certain threshold is not easy from those studies, but apparently low progesterone from all data is associated with lower ongoing pregnancy rate. In only 3 studies, the author reported that high progesterone may have detrimental effect on your reproductive outcome. We can conclude based on this table that improved reproductive outcome could be observed when serum progesterone is above certain threshold between 8.75 nanogram per ml to 32.5 nanogram per ml. This study can be criticized due to taking arbitrarily cutoff point 10 nanogram per ml and included 5 studies, including ours, and pooled the data. As you can see in the forward post graph, if the serum progesterone level is less than 10 nanogram per ml on the day or day before embryo transfer, it is associated with lower ongoing pregnancy rate. The odds ratio is around 1.5. So the next question, then, is it possible to rescue those cycles with low progesterone concentration? Actually, we tried to answer this question in 2021. Along with our study, the Polizos and Labartas group published the rescue strategy with sub-Q progesterone, and 2 more studies published more than, and this meta-analysis this year published in Fertility Study pooled all data from the rescue strategies. These are all cohort studies and observational studies. As you can see, if you provide additional progesterone as a rescue starting on the day of embryo transfer, this may rectify your ongoing pregnancy and provide a similar result with those patients with high progesterone groups. Only 1 study tested dydrogesterone. Of course, this needs to be replicated, but other routes can be used for rescue. Another study tried to make a rescue actually with micronized vaginal progesterone, but it was not useful for rescue. So until now, sub-Q progesterone seems to be useful to rectify the ongoing pregnancy rate on those patients with suboptimal progesterone concentration day before embryo transfer. As a clinician, we think that, I mean, every measurement and monitoring is a workload for our clinic, and it's a come up our mind, how about considering adding extra progesterone rather than monitoring serum progesterone levels, which is called an optimized approach actually, in a routine basis, rather than calling your patients day before embryo transfer. Actually, this approach is coming from the DIVINE study, first published in 2018, comparing 3 arms for HRT protocol, intramuscular arm, vaginal arm, and vaginal plus every 3rd day intramuscular arm. And when they compared the result in an interim analysis in 2018, the vaginal arm was prematurely terminated because of 2-fold lower ongoing pregnancy rate if you only provide vaginal progesterone for those couples in HRT protocol. This result was confirmed this year by Boston IVF. They included more than 2,000 cycles and compared the vaginal progesterone, vaginal plus every 3rd day intramuscular progesterone, and modified frozen embryo transfer cycle. Again, vaginal progesterone was associated with lower ongoing pregnancy rate, whereas if you add every 3rd day intramuscular progesterone, the results were similar with modified cycle. I was invited to write a reflection for those papers. Actually, based on the available evidence, I should stress that there is still many gaps for the luteal phase support in terms of combination and the dosage and way to go to find to optimize our outcome. Also, we have a RCT comparing 2 different approaches: individualized with using additional progesterone for those coupled with suboptimal progesterone, or optimized approach on the routine basis, starting combined progesterone routes. So these protocols need to be comparison for not only the live birth rate actually, but also the cost effectiveness rate. Also, regarding the progesterone use, intramuscularly it still has side effect for our patients. Other routes need to be tested for the optimized approach. Another question, whether if you combine a lot of progesterone and use it from the routine basis, the high progesterone is high progesterone detrimental for our reproductive outcome? Actually, initial two study, despite showing that there is a detrimental effect of high progesterone, I should stress those studies are very low sample size under the risk of type 1 error, and also the additional two new studies showed that high progesterone may have a detrimental effect. But again, these studies has limitation in terms of lacking and control confounders. On the other hand, accumulating data, including ours, showed that high progesterone don't have any detrimental effect. The latest one published this year in Fertility Study from Polizos group, including more than 3,000 cycles, added sub-Q progesterone on top of 60 milligram per day vaginal progesterone, and high progesterone was not detrimental on our reproductive outcome. So, until now, we discussed HRT protocol with vaginal progesterone use and different strategies, rescue and optimized. What about using different routes in HRT protocol rather than vaginal routes? We tested this year sub-Q progesterone and compared with the vaginal progesterone BID and sub-Q progesterone BID. Actually, the rescue strategy was applied for all patients. If the serum progesterone level is less than 8.75 nanogram per ml, we decided to make the rescue, and I should stress that 15.8 of the cases in vaginal arm need to rescue, but no patients in sub-Q group. Regarding the reproductive outcome, we found a similar result, and in an adjusted analysis, again, the odds ratio crossed the 1, and the results were similar. So BID vaginal gel was as good as BID sub-Q progesterone if you could provide additional progesterone on those couples with suboptimal progesterone levels. Regarding the serum progesterone concentration, as expected, sub-Q progesterone BID provide twofold higher progesterone on 1 day prior to embryo transfer. We did an analysis adding progesterone as a continuous variable and adjusting ongoing pregnancy rate according to confounder. This beautiful graph showed that actually there is no appearance ceiling effect statistically, and two arm is working well if you're able to do rescue strategy in this according to this study. A novel concept for individualization is measuring progesterone on the day of pregnancy test, actually. This is the first of its kind study published this year, Frontiers. You can measure your progesterone on the day of pregnancy test, and if your progesterone level is less than 10.6 nanogram per ml, according to this study published by Polizos group, you may rectify and rescue some of the miscarriage when compared with the no rescue group, and you can reach the level of normal progesterone group. Of course, this is the first study, need to be replicated by the other groups. Any of one in the room can make a study about this issue because we need more data for these concepts. So we completed the HRT protocol. Now move forward with the true nature protocol. We do have corpus luteum here, endogenous estrogen, then endogenous progesterone, and prime the endometrium. So personalized approach is needed for true nature cycle. To answer this question, actually, we have to answer another one. Is LPC is needed even though you have endogenous progesterone? Should we add additional progesterone on the top of endogenous in true nature cycle? I'd like to stress your attention to first and the last study. These are only two RCT, actually the RCT with vaginal administration, comparing the LPS with no LPS arm, and reported higher reproductive outcome live birth rate in the LPS group. A recent meta-analysis included the studies, but by mistakenly, the authors included one study from modified cycle. Please omit that one, which one is highlighted still, and take your attention to the here forest plot graph. Concordantly, first and the third study showed that LPS might be beneficial in true nature cycle. In those studies, LPS started on the day of embryo transfer, not earlier. I should stress this. What about monitoring progesterone in true nature cycle? Actually, only one study showed in 2020 from Polizos group reported that if your progesterone is less than 10 nanogram per ml in true nature cycle, it might be associated with lower ongoing pregnancy rate. In an adjusted analysis, they all include the blastocyst transfer, and 1/3 of your patients encountered with low progesterone if you take 10 nanogram per ml as a cutoff in true natural cycle. But those findings did not replicate it with 2 other studies, because as we all know, in early and mid-luteal phase in nature cycle, progesterone secreted in a fluctuational manner due to the fluctuation of LH. So single time point measurement may not be enough for true nature cycle monitorization. So in these 2 studies, the first one is a sub-analysis of the Wagner RCTs for LPS, and progesterone and high progesterone was not associated with low birth rate. The other one published this year, utilizing the only euploid transfers, and all patients had additional LPS, and if you measure serum progesterone before you start LPS in true nature cycle, your serum progesterone concentration was not associated with your reproductive outcome. What about the modified nature cycle? It's quite different. You know, ACG is triggered for ovulation, and then ACG-driven progesterone secretion started constantly. So 2 small-scale studies compared the additional progesterone modified nature cycle. No benefit of adding progesterone in those couples. We are waiting for the results of ongoing study. It might be about to publish because sub-study was already published. So, actually reported. Regarding monitoring progesterone in modified nature cycle, until last year ESHRE, we don't have any data. This data is a sub-study of ongoing RCT that I mentioned in my previous slide. It was presented in ESHRE 2022, and they compared the reproductive outcome according to serum progesterone levels and no association between reproductive outcome. So, it's an interim conclusion. Personalized approach with LPS with serum progesterone monitoring could improve reproductive outcome in HRT FET with vaginal progesterone administration, but may not be needed in true natural and modified natural cycle because progesterone fluctuates a lot in early and mid-luteal phase due to the corpus luteum secretional physiology. Let's move forward with the fresh embryo transfer, the neglected part of the neglected segment of the IVF. So we all know luteal phase is deficient in fresh embryo transfer cycle because supraphysiological steroid levels reduce the LH, and also we use GnRH agonist and antagonist, which is associated with very low LH level. So luteal phase is deficient, and we all know we know this from the beginning of the IVF, and then we routinely prescribe the progesterone for our cases with fresh embryo transfer. But one size fits all. We have to answer this question for fresh embryo transfer cycle. To delve into the progesterone production, I would like to discuss with you the contributor of the serum progesterone in fresh embryo transfer. 80% is coming from endogenous production, which is mainly driven by ACG, and also 20% is coming from exogenous production, administration of progesterone that we do to correct the luteal phase deficiency. But the question, is there any interpersonal differences between these 2 sources in terms of progesterone production? Actually, this is the landmark study by Wong et al. Published 2020, including 160 freeze-all cycle. All patients received standard dose of ACG, and in 10-time occasion, they measured the serum progesterone concentration and other hormones actually. And as you can see on the table, that in different time occasion, there is a huge differences between serum progesterone levels in patient to patient. The variation is high. So when you look at the peak time of the serum progesterone in those couples, around 40% reach the peak progesterone concentration on OPU plus 40, but some earlier, some later. So 65% had a fall on the day of embryo transfer from OPU plus 4 to 6. So what is the impact and magnitude of such drop on serum progesterone concentration on your reproductive outcome? And also, why there is an interpersonal such differences in circulating serum progesterone concentration despite using same dosage of ACG, because it might be due to the availability of ACG used after triggering. Also, it might be due to the quality of corpora lutea. Let's answer these two questions. Again, the Wong study measured the serum beta-ACG levels in 10-time occasion after the administration of the trigger. So you can see on the graph and the table that there is again a variation because of the uptake, distribution, and metabolism. It may differ due to the BMI, loss of confounder might be there. So regarding the quality of corpora lutea, I'd like to mention about the Thompson volunteer study. I want to quote this study. The discussion of this study is amazing. I mean, to understand the luteal phase, I recommend to read that discussion. So they include 10 volunteers and measure the daytime variation of serum progesterone. Also, we know all the data regarding the stimulation. I would like to take your attention on the patient number 8 and 7. As you can see, they produce the lowest serum progesterone concentration. They produce lowest. But when you look at the corpora lutea number, corpora lutea is very high. So, in conclusion, a large number of corpora lutea does not warrant a high output of luteal phase. So, quality of corpora lutea may differ from patient to patient. So, in interim conclusion, there is a marked interpersonal variation in circulating progesterone levels during early and mid-luteal phase in fresh transfer because of bioavailability of ACG, and quality of corpora lutea. Also, we all know from HRT, bioavailability of exogenously administered progesterone. So, then what is the impact of such marked interpersonal variation in our reproductive outcome? Not too many studies. These are old studies published 3 decades ago, utilizing cleavage embryo transfer and measuring only single time point of progesterone and comparing the conception and non-conception cycle, reporting similar reproductive outcome. None of the cycle had a consecutive measurement and trying to identify the physiology and the change in the serum progesterone concentration. To do so, we run a study. This is a prospective registered study which took 3 years to complete, and we published it this year in Human Reproduction. The inclusion criteria were female age less than 40, BMI less than 35, only blastocyst stage transfer was employed. Agonist and antagonist cycle were used, triggering with recombinant ACG, standard dose of ACG, and standard dose of LPS was provided for those patients. And we compared the serum progesterone concentration in 5 different time occasions: trigger day, OPU day, OPU plus 3 day, and OPU plus 5 day. Also OPU plus 14 day, which is not shown in the graph. As you can see, serum progesterone concentration increased from OPU to OPU plus 3 day. But there is a decrease in some cases and increase in some cases. Around 30% of the cases had a drop in serum progesterone concentration before the embryo transfer, based on this data. When you compare the patients with negative progesterone and with positive progesterone, I mean with higher progesterone, as you can see, there is a significantly twofold lower implantation and ongoing pregnancy rate, even in the adjustment for potential confounders. It's confirmed that negative delta is associated with lower ongoing pregnancy rate. So, should we monitor progesterone in fresh cycle to personalize approach and maximize reproductive outcome? According to our data, we have a drop in 1/3 of the patients. This is the first of its kind study. It needs to be replicated by the other groups, of course, confirmed. But based on this data, there are strategies need to be tested. We are currently working on those strategies. We may add a different route of progesterone as a LPS, or increase the dose, or we may go forward with the freeze-dose strategy for those couples who are under risk of low reproductive outcome due to the drop in progesterone concentration. So, to conclude with personalized approach with LPS and progesterone monitoring and rescue strategy could improve reproductive outcome in HRT fed with vaginal progesterone administration. Personalized approach with single-point luteal progesterone measurement may not be needed for modified and true natural cycle. There is a marked interpersonal circulating progesterone concentration in fresh embryo transfer cycle. This might be due to the quality of corpora lutea. In fresh transfer cycle, 1/3 of the patients encounter with a drop before the embryo transfer, and this drop may result with twofold lower ongoing pregnancy rate, and one-size-fits-all does not valid for LPS, not only in HRT but also in fresh transfer cycle. So we need to personalize LPS to maximize our reproductive outcome. Thank you for your attention.